This conference will now be recorded.
Okay, so we are grateful to our sponsors for making the recording possible. They include Bayer, Foundation Medicine, Janssen, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics. We also get support from many of our members in these support groups who go through to the website, AnCan.org, and search for the donate and make a donation to help support the ongoing operation. AnCan respectfully notes that it does not accept sponsored promotion. Any drugs, protocols, or devices recommended in the discussions are based solely on anecdotal peer experience, what we experience, and the clinical evidence that we have available. AnCan cannot and does not provide medical advice. We encourage you to discuss anything you hear in our sessions with your own medical team. And albeit I'm a doctor, my background is as a fertility doctor, and God help us if any of you end up pregnant after attending one of these sessions. So again, we have a couple of new people and a couple of people who would like to share and get some time. And in order to make sure everybody gets to speak, we'd like to ask you to be concise. And if I intervene or interject, I apologize for that. And we don't want anybody to feel cut off or left out. But let's start with Ignacio. If you can tell people the background of your story, that'll be a good way to get started.
Sure, I'd be happy to. Good evening, good morning. So my story begins in December 2022. So we're talking about slightly over a year and a half ago. And at the time, my PSA was high, which led to, and by high, I mean 4.0, higher than my GPA, that's for sure. Which led me to a biopsy. The biopsy revealed at the time that I had 7 out of 14 cores positive. All were 3+3. My doctor at the time, I was with my insurance. I don't know if I can say this or not, who I had, but anyway, he suggested treatment, which to me it seemed a little bit rash. So I did a lot of research, and I went on active surveillance. So since it was in December, I was kind of stuck with the same insurance throughout 2023. My PSAs were consistently between 3.4 and 4. In 2024, I changed insurance. I got an MRI, which freaked me out because the MRI showed that I had a PI-RADS 4 and a PI-RADS 5 lesion, which obviously it led to a biopsy. The biopsy revealed that the PI-RADS 4 was pretty much benign, which pleasantly surprised me. The PI-RADS 5, however, was 3+3. And then I got a second opinion from Johns Hopkins, and they kind of upgraded it to 3+4 with under 5% being 4. What surprised me though is that my new doctor, he did both a targeted biopsy as well as a systematic one, and again it came out with half of the cores being positive for 3+3. At that point, I pretty much thought that I'd be having treatment, and in fact, I had it scheduled for the end of this month until I attended PCRI and had the pleasure to meet Mark and Rick and Alexa, and also had the opportunity to talk in person with Dr. Scholes, and they all pretty much said that I can still be on active surveillance. So I canceled my appointment, and I intend to get a third opinion and see if I can stay on active surveillance. The most important thing that I learned, though, is that I wanted to understand why I had cancer in cores that did not show up on the MRI. And, to be honest, that was driving me nuts, because if I have half my cores positive, why don't these cancers or these presences of cancer show up on the MRI? And what I learned at the conference is that cancers instances of cancer that don't show up on the MRI turn to be genomically not as aggressive, and that is what is giving me hope that I can still stay on active surveillance. But if I can't, then I'm certainly up to pursuing treatment. I don't know if I went too long, too short, too much detail, not enough.
No, I think that's perfect, and it sounds like you got your money's worth from the conference.
Oh, absolutely.
Certainly, the point you make that not all cancers are going to progress. We kind of think when they give us a diagnosis of cancer, that's what we have. We have cancer. In fact, we have a lot of different clones of cancer. Each clone may behave differently, and not all of them show up on MRI. So it could be a function of the actual tumor itself and the characteristics of the genetics in those cells, whether they show up, but it could also be that it's very low volume. So I think it's not a big concern that some of the areas that they did on the targeted biopsy, there's a real move, I think, and those who are at the cutting edge to say, in terms of your treatment, doing those random biopsies really is not helpful. Now, there's some people who use biomarker scores, and if the biomarker score, like an ExoDx, is very high, they'll say, if you don't have any lesions, do a random biopsy. But I think we're going to find fewer and fewer patients getting random biopsies just because it doesn't add or change the kind of treatment you would get. Had you done any biomarker studies along the way, like a Decipher or something?
Yes, I did too. In fact, the first one was after the initial diagnosis. So now we're talking January 2023. And at that time, I did oncotype, which came back with low. I forget the number. I think it was 14 or something like that. And this year I did the Decipher test, and it came back super favorably with a score of 0.13. But this journey that we're all on, I suppose. In my case, it has been a series of good news followed by bad news, followed by good news, followed by bad news. So certainly I take the scores from oncotype and Decipher to be on the good news side. The bad news, in my case anyway, is that a substantial number of cores are positive, and also that that even though my PSA is in the 4 range, my prostate is fairly small, I've been told, and so my PSA density is actually high. It's 0.22. So so many factors and variables involved that kind of make the panorama a little bit murky sometimes.
Well, it seems like you're at a good place and you have a good approach for now. Be interested to know who you're seeing for the third opinion, and then also hope that you will take the time to sign into the active surveillance session, and I think that's on Wednesday. The other thing I think I want to remind everybody to go to the AnCan.org website, and you'll find the contact area, and you can put in your email, and you'll get a reminder email for the different support group sessions that we have. Does anybody want to comment? But actually, I asked you a question, so let me let you answer.
Yes.
Who are you seeing for your third opinion?
Right. So I was unaware that I could get a PSA test without a doctor's order. So I scheduled that for Wednesday. And then as far as who I intend to see, I am trying to find a doctor at UCSF. If anybody is in the San Francisco area, I went on the website, and it appears that to get an appointment with a doctor, you first have to talk to like a counselor, and that person directs you. To be honest, it's so new that I had time. But if anybody knows of an active surveillance proponent at UCSF.
So is this something new, Ignacio? Because in the past you've just been able to call up and self-refer or get an appointment at urology.
It might be new because as I stated earlier, I was about to get a treatment at UCLA, and to talk to Dr. Kishan, it was exactly as you say, sign into the website and request an appointment. With UCSF, which is closer to home, admittedly, I didn't spend that much time yet, but it appears that first that they have you talk to like a navigator or a counselor first. I'm not sure what the process is. I'll certainly try again as soon as I have time.
Well, look, if you have to speak to a navigator, it's fine, because just explain to them. I think the navigators may be aware of AnCan. If not, just say that you're a 3+4. You've been personally referred by AnCan, and you'd like to get an appointment with one of the docs that we mentioned to you.
Yes.
If you have any trouble at all, let me know, and I'm happy to drop Dr. Carroll a line and ask him if there's some new procedure, and tell him we've got a 3+4 gent who is very interested in pursuing active surveillance, and we'd like to get him to one of the docs. But if this is something new, then it'd be helpful for us to know about it, because in the past you've just been able to call up and make an appointment. I think the problem is the reason they may be doing it is they may want to make sure that you're seeing the right type of doctor. So they may want to know, because if you're an advanced patient, you don't want to be making an appointment with a urologist.
Right.
And, if you say specifically, well, I'm an active surveillance patient and I want an appointment with Dr. So-so-so, so that you might be able to avoid it, but they may be doing it as a filter. The
Sure.
question I have for the group to help Ignacio is we've got, I know Eric is one for sure, we've got a few 3+4 guys. Oh, and Stuart's another one. So do you, having heard Ignacio's story, are there any words that you have for him on whether he should lean, or if it were you, would you be leaning towards active surveillance, or would you be leaning towards treatment? Or maybe what pushed you to the point of deciding you needed treatment rather than being suitable for active surveillance? Govinda's got his hand up. Go on, Govinda.
Yeah. I had when I was diagnosed, it was 3+3. It progressed to 3+4 after about a year or so. So I was on active surveillance for about a year, and I decided to go for treatment because not by the absolute number of PSA, but the PSA velocity, that is the increase in PSA over a period of 6 months. So my PSA went up from 4 to 6 point something in a period of 6 months. That made me decide to opt for a treatment.
Okay, thank you. Stuart, let's hear from you.
Yeah, hi Ignacio. I am also a 3+4. When I was first diagnosed, I have a friend who's a doctor, and he counseled me to say, pursue this question of surveillance versus treatment before you go down the rat hole in terms of what type of treatment. And so I ended up talking to about 9 or 10 different docs. And what sort of led me to decide to treat was the fact that almost to a person, every doc said, partially because my Decipher was just high enough, they said, yes, you could go on surveillance, but their gut said that at some point in the future, 1-2 years, you'll probably have to treat. And it came down to a decision of, do I want to treat now when I'm healthy and everything else is okay, or do I want to wait and roll the dice? And we made the decision that now is a good time to treat.
Right. So that is actually consistent with the second opinion that I got. I should add, my current urologist, he classified me as unfavorable intermediate due to the fact that half my course came back positive. But then I got a second opinion, and that doctor, he classified me as favorable intermediate, claiming that he doesn't care about the volume of 3+3. He cares about the volume of 3+4, which is small. But he made the same comment that you made, Stuart, which is that he believes that eventually I will need treatment. And so it's a question of do I do it now, or or do I hold off for a while? And,
What was
and
I'm
yes,
sorry.
I'm sorry.
What was the recommended treatment that they proposed for you?
Well, surprisingly, my doctor is a surgeon, but he told me that that I'm a candidate for anything I feel comfortable except focal therapy, which basically means either surgery or a radiation. And as I mentioned earlier, I actually had SBRT scheduled at UCLA because I wanted the MRI guided SBRT. But I canceled it after what I learned at PCRI.
Yeah, I can ask you a quick question. Was that Augustine? Okay, this is Nick. I don't need to blab a lot, but I am also a 3+4. And without talking about my story so much, my question to you is, since your Decipher score was what I would consider to be very low, perhaps I could ask Mark to make a few comments somewhat similar to what you commented to me on yesterday, Mark, which is regarding potentially having your pathology reassessed by people that you knew, and this is my ignorance talking, that's why I'd like Mark to follow up, that you knew were experts in the field. They may change your assessment, or they may affirm that it's a low risk thing, and if nothing else, that gives you time to really figure out what you want to do, even if eventually you'd have to even if eventually you'd have to treat it. So I'm going to shut up. Mark, would you like to correct me, or if I'm making sense to you, would you like to roll on that?
I'm going to comment. I'm not going to smash your knuckles with a ruler or anything like that. And you listened well to what I suggested. I think Ignacio had the slides looked at, I think you said at Hopkins for a second opinion. And I think that, we've got that opinion and we've got the very low Decipher. I'm going to say that I agree with what his doc said, that the very low percentage of 4 is probably more important than the fact that 50% of the cores were positive 3+3. So I don't think in this case there's anything to benefit. I'm sorry, Ignacio, I forgot where you are from, but the testing that Artera does, looking at whether active surveillance or treatment is wise, is not available in California or in New York.
Right,
So,
right. I'm in California.
Okay. Paul, you had a comment. Okay. Did you raise the hand? Oh, Jim, did you have some comment?
I guess I kind of agree with the discussion that the 4 really, and the amount of the 4 is really more important than the 3. And I think that the Decipher score is very favorable. And if it were me, I would wait. I would pursue active surveillance and kind of see what spins out in the next year or so. I mean, once you have treatment, there's no going back.
Right.
And treatment of any kind really carries with it a lot of bad stuff that before you go into it, you really have to be prepared for. And so I think if you're going to go forward with treatment, you still have some homework to do, and we've got guys in the group who have had the various forms of treatment, and we could talk about that with you. But I think if it were me, I'd dig a little deeper in active surveillance and see if I could continue that for a while.
Well, thank you. I appreciate that. I do have a question that I don't know if it's appropriate for this forum or in the active surveillance forum, but having been on active surveillance for 18 months now, there is, in my case, a level of anxiety prior to each PSA. It's like, will this be the one that puts me over the edge? And also anxiety prior to the biopsies, right? Because they aren't fun by any means either. So, but I don't know how that compares to the treatment side effects. Sorry, go ahead.
I would suggest 2 things on that. that you might consider. First of all, some of the biomarker tests can help you go from PSA. Not every elevated PSA needs a biopsy. EpiSwitch PSA basically says that utilizing their biomarker, you can reduce 75% of the unnecessary biopsies. So I certainly think there needs to be screening. An elevated PSA doesn't mean you need biopsy. The second thing is I'd be real careful if each time you see someone, you go to a different lab. I ran into a problem last month where Quest told me less than 0.015, and then when I went to Scholl's office, they came up with less than 0.02. So it was reported with a different number of decimal places, and they didn't say the less than sign when they reported it to me. So it looked like it had jumped from the 0.15 to 0.2. Make sure that you're comparing apples to oranges, or apples to apples and not apples to oranges, and getting scared about a PSA that's not really elevated, and before you're making decisions. Paul, you've been patiently waiting. What comment would you like to make?
Just a couple of quick things. So I'm still riding active surveillance now, but I'm leaning heavily onto getting treatment because two main reasons, and other people probably heard the same story before. So number one is my tumor. I've been tracking my tumor size. So it's basically double. It's grown slowly, but it has doubled in about 2 years. Not to, so that's one thing. The other one is my tumor is budging against the capsule. Now, a couple of doctors I've seen said, well, this is common. However, yes, we all know that once it escapes the capsule, that's a whole different story. So the fact, I think the bottom, and I did have an appointment with Keyshawn last week, a tele-visit with him. And my Decipher is still low. My biopsy did show new core. Most of them are 3.3. One, interesting enough, was a 3.4. The 4 was very small. Decipher couldn't even read it correctly. But it's still, I'm seeing progress. There's no doubt that the groom is growing, and things are progressing slow a bit, right?
I think looking at the MRI to figure out the size and document the growth can be problematic. And it seems like that's the main thing that's changed is the size on MRI, and they're inherently bad at predicting the size. So I don't think a change in size would be simply a cause to leave active surveillance, but it's something that you might want to discuss with your docs there.
Right.
Nick, you are up, and if you could tell us a bit about your story, we'll get people to chime in and see where we can go for you.
Sounds good. Trying to be relatively quick here with my description. In 2023, in May of 2023,
hold on a minute. Someone else has their, maybe that's yours, Nick. We're hearing a lot of noise, but go ahead again.
Okay. It might be me because I'm standing outside. But at any rate, so in 2023, May of 2023, I'd had a PSA, actually in March of 2023, I had a PSA of 7.2. I did some diet and inflammation work in a few months, and it got down to 5.5, but my doctor still felt that we should go ahead and do a biopsy. So I got a MRI in June of 2023 and a follow-up a biopsy after that. The MRI showed nothing, but the biopsy showed out of the 12 cores, there was some pattern 3 cancer cells. they put me on active surveillance. And so in 2024, my PSAs had gone up to 7.9. So he did a targeted MRI in June of 2024, and there was a lesion about 1.5 centimeters in diameter that showed up. And so they did, the biopsy was targeted. There were 7 cores inside the lesion. They all showed pattern 4. And there were 3 cores out of the other 12 that they took that showed some 3. Very similar to the 2023 in terms of the other cores and the
Nick,
pattern.
Nick, when you were saying 4, was it 3 plus 4 or 4 plus 3 on those cores?
No, I'm understanding your question, and here's the answer. The pattern 4, the 7 cores in the pattern 4, the 7 cores inside the lesion, they were all graded as some cells of pattern 4. Everything else was a 3. And the grade that I was given, the Gleason score that I was given, was a 3 plus 4, and the percentage of 4 was around 2%. So I'll say less than 5.
Okay.
And I have been, I guess I'll say, researching what I should do at this point. As a side note, when I met Mark yesterday at the PCRI Conference, he was hearing me ask about a clinical trial in New York City called RTIRE. And one of the major reasons that I was asking about that is because I have been looking into focal treatments as a potential option for me. And that clinical trial included electroporation and also what they call low-dose radiation. I had a relatively long discussion with Mark about that stuff, and I'm going to be trying to find out what all that stuff really means. So my urologist in Vancouver, Washington here, he said to me that the biopsy results showed that I needed treatment. And I asked him if focal treatment would be an option for me. He said no, definitely not. But he did refer me to a radiologist. And they both told me that they felt that they could very successfully treat my prostate. I asked the radiologist if he felt that I could be a focal candidate. He said no, definitely not. I had gotten a second opinion from the Oregon Health and Science University, another surgeon, Dr. Strother, and Dr. Strother says to me that although he rarely recommends this, he felt that I was a very good, and I hadn't prompted him on this, I'll say that before I go on. He felt I was a very good candidate for focal therapy, especially because my pattern 4 cells were less than 5 or even less than 3%. So I've been trying to diligently look into things. That's one of the reasons I went to the PCRI conference. And I also was looking around for people who did electroporation so that I could get a second opinion on that. I'm going to be seeing an OHSU doctor about that in October. And I also, my brother lives in Tampa, and I got myself an appointment at Moffitt down there in Tampa. They do electroporation. But to be quite candid with everybody, I am very much in a mode of trying to figure out what I'm going to do, whether that needs to be a radical prostatectomy or radiation to do the same thing, or a focal treatment or whatever. So I really haven't made any decisions yet, but I'm trying to get as intelligent as possible as soon as possible. And one last comment, not that anyone on this phone call is in that RTIRE clinical trial, but that was one of the reasons I wanted to get on and listen to what anyone might want to say about any of this stuff rather than blabbing myself.
Okay, Nick. So you will see Stuart Jordan here. He has signed up, and I think you may have seen Dr. Nagar in New York about that now, but I have some comments to make about it. I reviewed this.
And one thing before you go on, Mark, I haven't, I'm on the phone, so I don't see anybody. But the other comment is, I've gotten an email response from the RTI-RFP people, but I haven't spoken to anybody. And go ahead, sir.
Okay, let's hear from Stuart first about your experience and thoughts, and then I'll kind of share what I know at this point. Stuart, your mic is off. You're muted.
Hi, Nick. I am participating in the trial. I just signed my official papers last week, and I am scheduled for the IRE this Friday. And why did I go there?
Going to New York?
Yep. I'm in Connecticut. I'm about an hour outside the city. And
gotcha.
Yeah. Quick background. When I was first diagnosed, my local urologist immediately said, "You're a great candidate for focal." And before I just basically took him at his word, I started going to all the centers of excellence in New York, and they all were positive on focal for me, but the research on recurrence is pretty high. And one of the reasons I called Weill Cornell was because they do have the interdisciplinary group that sort of guides you as to what your opportunities are, as opposed to you just talking to a single doc. And through that, I met Dr. McClure, who is the head doc on the Retire trial, and I met Dr. Nagar, who does the radiation portion of it. And what I like about that, and why I chose to go that route, is short of doing having to do the full treatment, the IRE has pretty good profile in terms of side effects versus recurrence, and then they throw the radiation on top of it afterwards. They think that they can reduce the risk of recurrence. And so it's a little bit more aggressive than just doing something like HIFU, but it was appealing to me because the last thing I wanted to do was do the focal and have to do it again.
When you do, how long, let me start over on this question. When you start your treatment, I'm guessing that the IRE portion that happens in a day, and maybe you wear a catheter for a few days?
Yep.
You going to correct me on that, Stuart? Okay. So then do you wait for any period of time, and how long is the radiation program?
Yeah, they said, Dr. Nagar said 6 to 8 weeks in between the recovery after the IRE before they start the radiation. There will be he's doing 2 treatments, which is, each one is 80% of a regular SBRT treatment, and it is done in the MRI. It is MRI guided. So I'll start this Friday, and
2 events. Two events is what I think I'm hearing you say?
Yes, 2 events plus the planning session.
Sure. I didn't mean it that way. And I meant that when you start the radiation, you're going to have 2 radiation events.
Yeah, but it's going to be 3 weeks total.
I'm great with you there. Oh, you mean the 3 weeks total for the radiation part?
Correct.
Gotcha. So, Mark, if you wouldn't mind interjecting, or Stuart, if you already know this on your own, Mark was talking to me about what I'll call gray count in terms of radiation, and you were saying 80%, but it's only 2 events. Do you know how many total gray, if I'm saying that right, that is?
Yes. Yeah. Stuart, do you have the number?
I don't.
Okay. So at least according to the protocol, it's 32.5 gray. I know when I was treated full treatment, we had 36 to 37. and they really draw a contour. So each individual spot, they can set how much that spot is going to get during treatment. The protocol specifies 5 sessions of meridian, or if it's going to be at MSK, then it will be the Alexa Unity. James, will you kind of comment on focal treatment? Because I think there's still a lot of controversy about the benefits, and then I want to come back and talk about the study specifically after.
Well, I think the controversy about focal treatment is recurrence, and I think what's sometimes overlooked in that discussion is that even with radical prostatectomy, the recurrence rate is somewhere around 30%. So, my personal view on it, and it's nothing more than that, is that if you've got a relatively simple procedure that's taking only part of your gland and leaving everything else intact, it's a lot better to go back with a recurrence from that and have another, you have all your options open at that point. I mean, if you have recurrence and you need to go back and have a radical prostatectomy, you can do that at that time. And likewise, you can have radiation, or, you have, in some instances, the option of repeating the focal therapy. And, that to me personally is very appealing.
It's also very appealing to me, which is something I sort of have to watch out for, if everybody understands that. In other words,
Yes.
One of the things I'm worried about is I don't want to outsmart myself, if I'm making sense by saying it that way, but I'm shutting up to listen to you guys now.
Okay. Let me give some of my thoughts on this. I looked into the study, and unfortunately, the study document doesn't mention anything about cardiovascular risk factors. For someone who has any irregular rhythm or has a pacemaker, beware. There is a fellow who got IRE who had a pacemaker in, and the pacemaker disconnected, and they weren't able to figure this out or reprogram it and recapture in time, and the fellow died. The IRE isn't necessarily more precise than the MRI Linac in terms of fall off or in terms of tissue destruction. I got full bore radiation, and it varied between 36.5 and 40. The seminal vesicles got about 37, and the lesion itself, most of the prostate got 40, and we got to 42, focused on the lesion itself. You're wearing a catheter, and that's for 2 or 3 days, and there is a risk of infection with it, and wearing a catheter is certainly not the most fun part of going through treatment. This is not a clinical trial as such. This is, we're going to treat you and see what happens. A clinical trial might be to get a group of men with situations like you have and randomize them and say some people are going to get the regular SBRT, some are going to get this program, and some might get just the IRE, and some might stay where they are. And then you compare over time and see what happens, see who benefits and who doesn't. I think in this case, all they can say, they're not going to be able to compare side effects with any other method because you don't know your population and people are being treated on different machines. So I don't think this study is really going to answer any questions. But I'm also concerned when we talk about keeping options open. I think that radiation after surgery is not the same thing as treating initially with radiation. If you're doing IRE plus radiation, I'm not sure. I know that they can retreat, but you're getting the gland with less than a curative dose. And I'm not sure that 32 and a half is enough to sterilize a disease that might be elsewhere in the gland. So I have concerns about this. Last night at dinner, Rick and Alan Adele and I all talked, and I think we were pretty much of the opinion that this wouldn't be something that any of us would want to consider. There were a couple of hands up. I know I'm opinionated here, so I apologize on that. But let's go with Stuart, then James, and then Govinda.
Just real quick, the current phase, which is just everybody is just is trying to prove the concept, is about finished. Next spring, phase 2 is going to start, and it is going to be a random trial against regular SBRT. That's step number 2. I asked, my conversation with Dr. Nagar last week was really focused on, tell me about the 80% treatment in terms of what's your knowledge, what's your experience, where does it get used? And he sort of referred to it as a cleanup level, and the place where he's used it in the past is as follow-up for somebody who's in a situation where they do surgery plus radiation. The level of dosage that he's doing is similar to what he does in that instance.
Okay, James.
Excuse me, go ahead.
Yeah, I was curious how everybody feels about the value of a PSMA PET in this circumstance, and whether that's offered as part of this procedure.
Yes,
because
it is part of the study.
It is, okay, because I would think that would be very important where you're leaving seminal vesicles, for example, intact and other structures.
Yes, so the answer is yes. I had a PSMA 3 weeks ago.
Okay, and you're all good.
Yep.
Great.
Nick, I'm wondering if you have gotten the Decipher score and whether you sent your pathology off for a second opinion. I forgot from our discussions, spoke to so many people.
I did send it off for a second opinion, but I'm unaware that they did anything other than read the same slides, like they didn't cut new ones like you had talked to me about yesterday. And on the Decipher score, I'm sorry, I should have said that to you guys. So one of the reasons I said before to Ignacio that, boy, his Decipher score sounded pretty low was because mine was 0.58 in 2023, just below the high. It was considered intermediate, but sort of in the high range of the intermediate, at least on the graph that I looked at. And they did another one to check out the, quote, pattern 4 inside this lesion this year. So I got another one done that I just got back the results last week, and it had the same score. So my Decipher score, we've had it done twice, from the biopsy in 2023 and now in the biopsy in 2024 on the pattern 4 stuff, but the Decipher score was the same, 0.58.
Nick, how old are you? Nick, how old are you?
Oh, sorry, I missed that question. I am 69, will be 70 in May of 2025.
Okay, Govinda.
Yeah. I just wanted to put in that I took SBRT treatment under a clinical trial about 8 years back. It was total of 40 grays in 5 sessions. And after about 8 years now, I am practically normal. I had a recovery period of about 6 months, and then things started getting normal. And after about a year, I was near normal. And after 8 years, I have the latest PSA reading was 0.06 or something, and I lead a normal life. But in my view, or in my point of view, the clinical trial is extremely good because you get more attention when you are going to a clinical trial, and it was quite useful and a good experience. I took it in Oddity Cancer Center in Sunnybrook Hospital in Toronto.
Okay, thanks. Let's move on now. I just wanted to check, Mark, are you going to need some time this evening? Okay. And Don, will you need some time this evening? Can you unmute yourself? Okay, well,
I'm good, Mark. Thank you.
Okay, great. And yeah, our fearless leader would like to add.
Yeah. So I just want to make sure my understanding is correct and everybody else's. Stuart's using electroporation, but he's not doing it for focal because he's combining it with the SBRT, and the whole gland is going to get treated. The issue is we don't know the extent of the treatment because that's what the study is all about. And what we're trying to figure out is, are we able to do electroporation and give a lower dose of SBRT? Is that as good, better, or worse than if we were to treat the whole gland with SBRT? So it isn't a focal choice that Stuart's making, but he's combining a focal therapy with another type of therapy and treating the whole gland that way. I just wanted to clarify that was my understanding of what this is about. I will say with focal therapy, the reason that I'm generally not in favor of it is because in the recurrent and advanced group, we see too many men coming back to get treated a second time. Obviously, that's because we're the recurrent and advanced group. We don't see the men where it succeeds. So I certainly acknowledge that. And I don't think there's anything wrong with focal, provided you select the right patient. It's really important to select the right patient. And one of the best ways to make sure if you're right for focal is to get it at a center of excellence, because they're not pushing the product. And unfortunately, a lot of the doctors, the independent urologists who administer focal, are pushing the product. And they'll tell you you're suitable when you're not really suitable. And we've seen that too often. And Dr. Mark here is a perfect example of where that happened. And the doctor who treated him is renowned for treating people who are not appropriate. He'll treat people who are 4+4, which is a scandal in my view for somebody who is looking at focal treatment. Jim Schrait's absolutely right. In that overall we see a recurrence rate of around 30 to 33%. For surgery, but the problem with focal is we see a recurrence rate of about 50%. And we've done webinars on focal on AnCan. If you go to the AnCan website, you put in focal therapy. I think webinars will come up. We did one with Dr. Klotz not so long ago, and he was one of the people that highlighted the 50%. So, there are pros and cons for focal, but it isn't a silver bullet to avoid the side effects of more extensive treatment that a lot of men think it might be. Stuart, you have your hand up.
Yeah, I just want to echo what you said because I started with the local doc who was pushing focal. And when I started going to the Centers of Excellence, NYU, MSK, all of them emphasized that you had to be, that you had to be qualified to be treated, that they were not just going to treat anybody. And they were, and they're very serious about that. NYU probably more so than the other two. They said, that they weren't going to agree or promise to do anything until they were convinced that you were an appropriate candidate.
Yeah, thank you.
Okay, well, thanks. That's a discussion that I think is going to continue in future meetings, and we look forward to. I look forward to the clinical trial where they randomize, because full SBRT may not be that much more than doing the focal plus the chaser. It's kind of like in the old days when they did brachy with a boost on EBRT. Anyway, let's move ahead. Eric, you're up next. If you can tell us your age, where you're living, and a little bit about how you came to join the Prostate Cancer Club.
Okay, I'm in Little Rock, Arkansas. I'm 72 and actually be 73 in November. And my PSA crossed the 1.0 mark in 2011, crossed the 2.0 mark in 2015, and by the time it turned into around 2017, I crossed 3.0, and I was worried by that point. I talked to my doctor and I said, when do we have to do something? And the doctor said, no, that's normal. It goes with your age. Don't worry about it. And I wasn't comfortable with that. And I went to a screening at Arkansas Urology. Once a year they do a free screening, and I had a PSA there, and it was over 4 by that time. And they suggested I come in for a biopsy, which I did. And I came back, and I didn't know what the word Gleason meant, and I had no idea why 3 + 4 made 7 and 4 + 3 made 7, and there was a difference. I didn't know what any of that stuff meant. That's where I was in the scheme of things. And their lab came back and said I was a 4 + 3. And I was introduced by a friend to a group in Little Rock called the Arkansas Prostate Cancer Group, and that's actually where I met Cosley, and a little later on. But in 2018, I was in that group, and they suggested that I ask for a second opinion, and I sent my lab results, or my lab material, back to Johns Hopkins, and I guess it was Dr. Epstein, is that right?
Yes.
Yeah.
That reviewed that. Meanwhile, while that was happening, they did another test called the Polaris test. And I'm sitting there thinking, I had an uncle that died of prostate cancer. His doctor said, oh, you're going to die of old age before this ever gets you. I remember finding out that his PSA pegged the meter at over 4,000. It stopped. And he died of a metastasized cancer that went into his bones, died of bone cancer from prostate. And I said, I'm not gonna just mess around. I'm not gonna stay in this wait and see. And I mean, later on they tried doing the seeds and everything in his case, and none of that helped in his situation. So I'm sitting there thinking, I've got to do something. And my doctor that did the biopsy said, I want you to talk to the radiation guys around the corner here. And boy, they were smooth, and so they kind of sold me radiation is the way to go, and that was really, really cool. Meanwhile, Johns Hopkins comes back and says, well, I'm here to tell you it's not 4 + 3, it's 4 + 4. You're an 8. And so I said, whoa, okay, not good. So I had an MRI, that told them apparently that the cancer was still contained. It had not escaped into the body. That was good news anyway. And so my options came down to radical prostatectomy or radiation. And I found out that Johns Hopkins had come on back and visit us. We'll run you through everything, do a kind of a one-on-one deal. So I opted to go back, and I did that. And I talked to their chief of urology, surgeon, and their radiation team, and they had a few other options and things. But it was amazing when the chief of urology, who was the surgeon, said, you know what, just skip the RT or the RP and just go right into the radiation, because the chances of reoccurrence with the RP is, and he pulled out all his numbers and things like that. And I think he said somewhere around 35% or somewhere around that, given my circumstances and my PSA, and he had all these numbers, and that didn't sound too good. And he also told me something else I hadn't heard before. He said your prostate is about the size of a pear, and the surgery is going to be difficult, and all this. Whoa. And
Eric, what's RP?
A radical prostatectomy.
Gotcha.
And so that gave me a lot to chew on. And I came back and I talked to my doctor at Arkansas Urology. Well, before I did, though, when I talked to the radiation guys, they used a term that rang a bell from my Navy days. And I said, tell me why you can only do radiation once. And he said, because we give you the maximum permissible dose. And those words were the same thing we used when we talked about nuclear, biological, and chemical warfare in my military days. And I said, oh. And then all of a sudden I put radiation into this box that said, that is the gift that never stops giving. If you get to maximum permissible dose, that means the radiation is still burning in your body until you die, which is why people have this problem with things that continue to happen. That's why you finish your radiation dose and then everything looks good, and then 4 or 5 years later things are starting to happen. You have other symptoms. That made me really do a real double take. And I came back to Little Rock and I got together with that group and I went around and I said, tell me guys, here's the situation. What would you guys do in my position? And everybody went around and gave me their thoughts. But I knew I didn't want to finish 2018 without having something done because of what happened to my uncle. My Polaris score came back. It was like 3/4 on the aggressive scale. So this thing was growing and growing fast.
Yeah.
And so I knew I had to do something.
Eric,
So
have you done treatment already?
Oh yeah, 2018, before 2018 finished, I had the surgery.
Okay, so Eric,
Yes, sir.
of the greatest of respect, this isn't the right group for you if you're still dealing with prostate cancer. The group you need to be in is what we call the high risk recurrent advanced group. And that group meets tomorrow at 6 o'clock Eastern. I think Arkansas is on Central, isn't it? Are you on Central? Yes. Yeah, so correct. 5 o'clock. And we don't talk about recurrence in this group because there's enough anxiety already.
I see.
In the other group, we do get into recurrence, and we can talk to you if your disease has come back. I had similar diagnosis.
PSA is 0.
Okay, so
you're actually in remission now.
So you are in remission. So
absolutely.
What are you just here to share your story, or do you have issues that you would like to discuss?
My friend Cosley said, hey, this is a great group. There's a lot of information. Why don't you tune in? So I'm here for the first time tuning in.
Okay, so
I paid him to say that.
okay, so let me just let me say a couple of things. First of all, thank you for speaking. I think the reason why a lot of men like myself who are in a similar situation to yours do not choose surgery is because we don't want to roll the dice. There was a 70% chance in my case that my disease was going to come back if I did surgery. So I didn't want to do surgery with a 30% chance of success when I knew I was going to have to do alternatively radiation and hormone therapy anyway. The advantage of doing the surgery was probably about 3 or 4%. There's nothing really good. There's no real good hard information on how much the surgery adds if you're doing hormone therapy and radiation. That said, there are guys like yourself who are willing to roll the dice, and we say to you, God bless you. And if in your case you are 6 years out, is that right? You had the surgery in 2018 or 2019?
Yes. You want to know the downside of what I'm dealing with?
What's the downside? May be from the surgery, incontinence,
Yes.
or erectile dysfunction.
ED. Yeah, I've had to go the implant. Yeah, I've had to go the implant route.
So, we have other men, as it so happens, we have other men on this call tonight, moderators who have had similar experiences with ED and incontinence.
Right.
But we'd rather discuss that, and we'd be very happy to discuss that with you tomorrow.
Okay.
And the ED aspects will be the same. I'll be on the call, and others will be on the call. I hope to be back in Arizona tomorrow when I'm on that call. So God willing, and we'll talk to you about it. But again, we sort of skirt around these issues in this call because that's the scary stuff that we hope isn't going to happen. And that's what we have an active surveillance group, and we don't talk about treatment in the active surveillance group. Those guys have to come into this group. As people like Eric from Atlanta and Stuart will tell you, they've got to come to this group and the same thing. So
I wanted to share a few things as well. There was one red flag in your story, and that was that you got the biopsy, and it appears that it was after the biopsy that you had your MRI. Is that true?
That's true.
So in that case, it's like doing a biopsy with pin the tail on the donkey. You don't know if you're really aiming at the worst spot. So you started out 4+3 and you got to 4+4, but it may have been a whole lot worse if they were targeting a lesion that showed up on the MRI. So that was one red flag that has me concerned about the process. In this day and age, to do a random biopsy without getting an MRI first is just not standard of care or good medicine.
In Eric's defense, we knew that in 2018, but it wasn't as one. I mean, now a lot of the community urologists are doing targeted biopsies. They should have been doing them, and they were doing them at centers of excellence at that time, but today it's more unusual.
But that's why we're telling people go to a center of excellence, because we don't know what they're doing today.
Right.
That's going to take 3 or 4 years to perk down.
So Eric's a great example of why you need a targeted biopsy.
Yeah, it was discussed as experimental back in 2018, at least internally in Central Arkansas. It wasn't. It was not common. It was not common.
The other thing that probably has changed since then is improvements in radiation therapy. So when I make these comments, I'm not making it for you because obviously you've addressed and been treated already. But you can repeat with the modern radiation, the margins and the targeting and the ability to see lesions are far more precise than it was before. Using PET scans and finding lesions, obviously PET scans weren't available back then to look and see if there was any spread outside the prostate. But even when that spread is detected and there's lymph node involvement outside the gland, going ahead and doing surgery when the surgeon knows I've got some positive lymph nodes on the left. If they repeat the PET scan after surgery, there's about a 30% chance that you will still have those positive lymph nodes. So the idea that surgery is going to get disease that you wouldn't pick up with radiation is just not really clear. So that's the two things. I just want to make sure people know you can retreat. And in a situation like yours, where you have more advanced disease and you're looking at doing the radiation or the surgery first, and then you need radiation, radiation done after surgery is far more complex than at the time of the initial diagnosis, figuring out we're going to treat this with radiation, knowing the extent of disease. That's changed. We're making major advances, and unfortunately, we didn't know all this stuff back in 2018. So, okay, let's see. I see a hand up. Stuart.
Dr. John.
Oh, hi, John.
Dr. John, 1 second, Stuart. Want to welcome Dr. John, who came in late, who is actually one of our advanced moderators. He didn't
Alexa, hi. Hi, Rick. Look at the whole gang. How come I'm not there?
Here, Dr. John. And Dr. John.
We even have Andrew, the mascot for
AnCan. Where's Andrew?
Yeah,
I thought Andrew was a real dog.
He is, and we'll get him back to show you before we finish. But that said, we're going to go to Stuart, but I do want to come back to you. I know we've got questions, but I do want to come back to you because Ignacio, who we met at PCRI, has one of his issues is scanxiety. And Dr. John is an advanced prostate peer, but his day job in the old days was as an addiction psychiatrist and a pain psychiatrist at the University of Connecticut and at the VA. And I'd love to hear his thoughts on dealing with scanxiety, especially since I think he might even be a peer to scanxiety as well.
You got that right.
So
all right, let's go to Stuart, and then we can get back to me. And I also have something I want to reassure Eric about.
Go ahead, Stuart.
I'm sorry, I had the hand up by mistake.
Okay. Well, you go ahead and reassure Eric, and then we'll get to some of the questions, and we'll come back to scanxiety.
I just wanted to tell you that radiation is not still, to use your word, burning in your body all this time. It works for a short time. It's an attempt at cure. It kills cancer cells, and then it stops being radiation right away. You don't have to worry about it's still acting on your body after the treatment.
I know they're making improvements in targeting, and they're doing something now where they're actually putting something in your body where it's going to find the actual prostate cancer wherever it exists in your body. Is that what you're referring to?
No, I'm referring to beam radiation, which is what I assume you had. And I think what you're talking about is using radionuclide therapy, where a radioactive atom is attached to a molecule that can find your cancer in your body. And then the attached radioactive atom kills the cell that's nearby.
The beam treatment was the option that was offered to me at the time, and that was the concern where there were other things that would be impacted because it was not as precise. It was not the I guess the what do they call it, the beam or the knife precision. We did not have that option locally that is much better. We do now. I mean, we now have the more precise, what's the word that I'm looking for, where they have the beam that goes in, it goes in and just does it there locally.
You're thinking of proton, but that's never been shown. That's marketing hype. There's no evidence that shows that proton is any better and that the Bragg effect is real. In fact, in the near future, we're going to see published something called the COMPARE study, and whether the inside information that was leaked out is real or not, but I don't suspect that that's going to show any advantage. Aiming with MRI, which allows more precise vision, the ability to detect movement and adjust the beam while it is on when there's movement in the prostate, allows for more precision. So whenever they treat, they encircle, they see the tumor on the MRI, they draw a circle around the prostate, and then for safety, they add a margin with a regular machine. They're going to add 5 millimeters, so they're burning a lot more normal tissue. With the MRI guided radiation, they only add 2 millimeters. And that was one of the things, Stuart, that's the advantage in this. In the RETIRE study, the margins that they're adding is only 2 millimeters. So that's a great margin and should really have very few risks at all from that, what I'd expect. But I wanted to double what was said earlier by Dr. John, and that is that the radiation stops when the beam stops. If you have seeds put in, you could still be radioactive. If you have a PET scan, you'll be radioactive for a day or two. But what happens is all these cells are exposed to the radiation, but they don't die right away. It comes up that tomorrow is your big day. You're a cell and you're going to divide, and unfortunately, you die. In the process, the tissue will shrivel up and it can restrict blood flow. You can have abnormalities in the bladder and in the rectal wall, and just inflammation in those areas that pop up later. They can pop up to 2 or 3 years after radiation. But with the newer methodology, that's going to be a whole lot less than it was back in 2018. I wanted to go along because we have some other people here who wanted to speak up. Did we get everybody? I think we got all the hands up. So Tim, you're up now.
Yes, I'm 63 years old, 6'1", 160 pounds. 4 months ago, diagnosis 3+4. And I'm on the verge of treatment, mostly because of anxiety, really. So I've been talking to Mark about SBRT, and I'm on the verge of starting SBRT at Moffitt Cancer Center in Tampa here. And I have a space OR scheduled for September 17th, and I'm got anxiety about that too. So I wanted to know if anyone had SBRT experience and specifically the rectal spacing to discuss any thoughts on that.
Who would like to share their experience with Tim? Okay, well, I will. Oh, okay, Mark in West Virginia.
Can you hear me now?
Yes.
Okay. I had IMRT and 45 treatments with a spacer last year, and there's no issue with the spacer. You don't even know it's in there. It's not uncomfortable. You I wouldn't do radiation without it. You don't even feel it. You don't even know it's there. And when they put my markers in, that's when they put my spacer in. So it was just part of the. Is that what you're talking about, Mark or Dr. Mark? Are they talking about?
Well, there's 3 different ways to separate the rectum from the prostate. One is spacer gel. That was the first one. The other is one called Barrigel, and then there's now a balloon called BioProtect. I'm not a big fan of spacer. I chose not to do it. When I went through, 50% of the guys did spacer, and the other half did not. It does somewhat depend on the location of the lesion, so you certainly want to discuss this with the radiation therapist. One of the advantages of Barrigel is that it flows more evenly, where the spacer kind of freezes up real quickly. So you may have good spacing on one side, your right side of your pelvis, but on the left side, it doesn't separate it. There's also about 2% of the time where they get the injection goes into the wall of the rectum and can cause very severe pain and serious complications, rectal complications. I think spacer, I think the Barrigel may be safer in the long run, but it's always safest to do the thing that they have the most experience with. But I would certainly ask. It appears that spacer has some advantages. Would this be an option for me? That's something I would consider. I think more and more they are moving towards, even in SBRT, doing the spacer. And if you've done the Prostox test and that were positive, then I'd certainly be more concerned about using spacer to protect the rectum, some spacing gel or balloon to protect the rectum. So that's my 2 cents. Let's see. Anybody else have their hand up on this? Anybody use spacer? Govinda.
Yeah, I didn't use spacer. The option was given to me, but at that point of time, that was back in 2017, it was not a proved thing in the sense that there was not much of experience using it, so I didn't use it. I had my SBRT treatment, 5 sittings, and after 8 years now, the results have been extremely good, and there were some side effects for about 6 months to 1 year, but everything practically came back to normal after that. I'm quite happy with that. And I took the treatment in Toronto Auditory Cancer Center in Sunnybrook, which is a center of excellence in Canada. My experience has been extremely good, and I'm happy with that. And I'm happy I chose SBRT at that time. In fact, at that time, it was not an approved protocol by the Canadian health system, so I took it through a clinical trial, a randomized clinical trial. So I think
Mark,
I had a very good experience.
What dosage in gray units should I be
It was 8 grays in 5 sittings, total 40 grays.
Usually the prostate will be 40 grays depending upon the lesion and the Gleason score. On my case, I had I think it was a 4, and they boosted the lesion itself to 42 gray. The seminal vesicles got 37. One of the advantages of the MRI machine over the Proton and some of the other machines, you can really draw out specific areas and assign a dose to each spot. There's not a lot of spread in the dose that you might have otherwise. John S., did you want to comment about using a spacing gel?
Yes, I went to see Dr. Nagar last week, and he did indicate spacer is to be injected. Now I'm a little concerned. I guess I don't know.
I would ask if there's an option. I think that they both are good. The majority of the people do well, but I'd ask, what's the risk of complication? No matter what you do, ask what is the risk of complications, and how might I benefit from using this? If it turns out there's 2% complications from using it, and the benefit is 2%, then I might not do it. If it cuts the risk of significant bowel problems by 10%, I might take that 1 to 2% risk of a side effect. So that's something that you should discuss with Dr. Nagar.
And I would like to say one thing on this, which is that we listened to Dr. Roach, who, in full disclosure, is my doc. And he's never been in favor of the spacers, because he thinks that they only benefit a very small number of people. And essentially what he said at PCRI is they get put in because it makes money, and the doctors can charge for them. So now, in my particular case, I had a weak bowel going in, and I don't think the radiation helped me any, and maybe the spacer, I might have been a great candidate for spacer. I don't know. So there are pros and there are cons. I mean, Matt pointed out a whole list of flaws in the original trial that approved spacer. So that's another issue. Was it right in the first place? We don't know. The problem is it's become something that's sort of standard. People hear about. They think that they should be getting it. I don't know.
Yeah,
honestly don't know.
I did have one guy that I was talking with who ended up with bleeding and pain, did hyperbaric oxygen. That didn't work, and ended up with a colostomy because of injection of the spacer into the rectum wall. So I'm not sold. I don't know what I would do now, but I'm 4 years out. I don't have any rectal issues. I think it'd be different if you're doing CT guided than perhaps if you're using an MRI machine with just a 2 millimeter margin.
Okay.
I think as our margins are reduced, the risk of this bowel disease or bowel exposure might be less, but it also depends where the lesion is. So that's why you really need to have a good conversation with the radiation therapist and ask, have they had any complications? Let's move on. Causley, you're up.
Before we come to Causley, I just want to tell you there's been an uprising in the chat window, and I stand down in that there are moderators here who feel we can and we should talk about issues like ED, and we should benefit from the experience of people like Eric. So I'm going to defer to them, and at some point, if you want now or later, if you want to come back to that discussion, then I definitely stand down. I just don't want to freak anybody out. That's all.
I'm just feeling, Eric, that we haven't addressed your questions tonight. Can you tell us really what you're looking for, in a few minutes, and see if we can get back to you and help you out a little bit here?
Me?
Because
I just want to hear.
I don't think Eric is looking for anything. I invited Eric to come and join us, join the happy bunch of us. He's
want to hear
already been
what's going on
treated
in
and
the
all
community.
that.
Yeah.
Okay.
Well, we are glad you're here, and I think your experience is important, and hopefully you will come back and pipe up when other people have questions where you feel like your experience would be helpful.
So
I was just concerned that maybe we hadn't answered your questions, and we didn't, and we don't have any intention to shut you down.
No, you didn't scare me away. No, but I'll try that other group too. So.
yeah, no.
All right.
I was going to say, hey, if anybody wants to ask Eric about penile implants right now, here's your opportunity, because we don't often get men who have penile implants. So if anybody's interested, anybody has a question at this juncture, Eric, is it okay if we talk to you about that?
Sure. Yeah, absolutely.
So here's your chance. And if you see Eric again in this meeting, I'm sure he'll always be gracious enough to answer a question.
Cosley's got my my SMS text. If the meeting's going on and he says somebody's got a question for me, he can text me and I can try to tune in here. I mean, whatever.
Okay.
Okay, Cosley, you wanted some time tonight.
Yes, Mark. I found out something today called the ProAct adjustable continence something. And I didn't know what it was. I gather it is something they put in for people with urinary incontinence. It's a replacement for a little ball that replaces your prostate, or resides in the same bay where your prostate resided. And I was wondering if anyone has any knowledge of that or any information on it.
John, did you have some information about this or experience?
No, I don't know. I didn't quite catch the name, Cosley, but it didn't sound familiar to me.
It's called
especially the description didn't sound familiar.
It's called a ProAct, PROACT, adjustable continence or incontinence device, I think is what it is.
I think this was mentioned at one of the sessions at PCRI, and it was a device where there is a pump that's placed. The pump is in the scrotum, and there's a tube that goes up. There's a reservoir inside, and then the fluid is pumped in. You can pump anywhere from 1 to 5 times, depending on how much you want to shut things off. Yeah, that was what was shown yesterday at the meeting. And there was a urologist from Florida who spoke at PCRI and said that he had good results with that. He used that or the sling, but he was very favorable about how that might be useful.
Yeah, I see it online now. It looks like it's different from the traditional artificial urinary sphincter.
Yeah, it is something completely different from that. It's not the same.
Yeah.
But I just wondered if anyone had any working knowledge of that. It's something new I found out today, something new to worry about.
I think that might be in the other group tomorrow as well. You might get better catch there. Was that an issue for you, Eric, at all? Had you had issues with incontinence or just the ED side? You're blocked. You're muted.
Yeah, I've had a little bit with incontinence. It's kind of been on and off, and I've had to use some pads. What I've noticed is, I've learned a lot through this process. I did not know that guys had two sphincters until I was starting to deal with this problem. And when they took the prostate, they took sphincter number 2, and I said, "Ooh, it's a whole different world." And what that means is when the alarm bells go off, you don't wait. I used to be able to wait, no problem, but not anymore. And if I don't pay attention to nature, then it starts leaking, and it's a little bit tougher to deal with. And if you start getting lazy about your exercises, it gets to be more of a problem. So, but it's not as bad as some guys that just have no control. But I find myself wearing pads when I go for a long trip just to be safe and that kind of thing. So,
Greg in Detroit, what can we do for you?
Good evening, guys. Going along the same venue as Causely, in my archives the other day, I ran across an article that was probably about a year, 18 months old, and it spoke of hyperbaric oxygen therapy as an adjunct to chemo and radiation therapy to enhance the effectiveness and efficiency of the treatments. And one of the diagnoses for which it's been studied in its application was, of course, prostate cancer. And I guess I was wondering if anybody has run across a similar article or know of any studies or implications for which this has been used.
Well, the thing that I'm familiar with is that if there's radiation cystitis, hyperbaric oxygen may be up to 95% effective at controlling some of those symptoms. I remember back probably 30 or 40 years ago when I was on the oncology rotations, we talked about hyperbaric oxygen, but coordinating that with our treating our patients was such that it never really happened and there was no interest despite some evidence. As far as prostate cancer, I've come across things, but no well-designed large studies. And there are some risks with cataracts associated with hyperbaric, depending on the depth that they send you and how long you're in the chamber. But does anybody else have any experience looking at hyperbaric?
Well, I mean, we've had a number of men who have gone through hyperbaric from the recurrent and advanced group. I would say results have been about 50-50. Some guys have definitely benefited from the radiation damage, both cystitis and proctitis, and the rest really have not. I remember the first guy that we ever had go through it. This was in 2017, I think. It was right around the time I'd moved to Arizona. And we were not aware at that time of the ocular issues. And he did have problems, corneal problems as a result of the hyperbaric treatment. And we learned from that if anybody's going through, we have to tell them, just make sure you discuss about what the downside is. I mean, Dr. Mark, you were thinking about hyperbaric treatment recently.
Right, but I think you were talking, Greg, about doing it to radiosensitize before radiation.
Well, the way the article explained it, it would be applied subsequent to radiation therapy to enhance the overall effectiveness of it, and thereby the thought was that potentially the dosage of radiation could thus be reduced somewhat, although nothing was definitive on this. And there's been some limited studies across the U.S. in its application. But they never brought up anything about the ocular issues involved, although as with any therapy, there's always a risk of something.
I think
But
I would, yeah, I think at this point I'd consider it in the same realm as hyperthermia and red light therapy, that there may be benefit,
yeah,
but you're not going to find a well-designed study that looks at it. And it's going to be hard to do that study, uh, to come up with something like that and ignore what would be more definitive studies where there is data.
right. Okay, fair enough. I mean, that's it just kind of piqued my interest in terms of the advancements that we've always talked about, especially in the last 5 years on, for prostate cancer, and this being possibly something in the future we just don't know at this point in time, although it sounded somewhat promising.
John just posted a link in the chat room. That's the little square box between the person and the gear, possibly in the upper right hand corner of your screen.
It's open to the organizers, so we'll have to recopy it and
Oh, okay.
And someone, if it's of general interest, we could forward it. I've posted it, but I haven't read it. I just found it while we were talking.
Okay.
It's 4 years old.
John S. What's going on with you?
Oh, did I raise my hand, or are you just asking, Dr. Moore?
You had said earlier that you needed some time.
No, he
No.
came in late.
You came in
No.
late. Okay.
No, I came in late. I'm sorry.
Everything okay?
Yeah, just the space, or I came in late and I heard the conversation, and yeah, that's been playing on me, and I should have asked Dr. Nagar last week about it, and I guess, I don't know, I guess I'll have another follow-up. I don't know.
I'm sure you'll have another time to discuss it. Alberta, we didn't get you when you first came in. Are you going to need some time for discussion tonight?
No, I'm okay. Thank you.
Does anybody else have any comments? Ignacio?
Not a comment, but a question, if I may.
Sure.
I heard you say earlier that if a Prostox score is low, that you don't need, or you're suggested that you don't need the space or a spacer, right, in general. But I was
I'm not saying that, but go on, finish.
Okay, I was under the impression that the Prostox score was a prognosticator for potential GU issues, not GI issues.
I think it's for both. I think it's for any normal tissue that can be damaged. That's certainly my understanding with it. And I don't know that I would say absolute in any regard. I think there are a number of factors that need to be considered. As Rick had said earlier, if you're entering into this situation with rectal issues already, or with bladder, I mean, it's not gonna, the spacer isn't going to affect bladder, but if you're having rectal issues already, if the lesion is very close to the rectum, then I'd be concerned. If there's bulging posteriorly, a lot of times they're not going to want to use the spacer, because the thinking is you may have cancer cells spread to the anterior wall of the rectum. And this is one of the things that Mac Roach said the other day, is that you may have cancer on the other side of that space, and you put the spacer gel in there and you're pushing cancer away from where it would be treated. So I think that's a discussion, and they'll take a number of things into account. Important things like that, though, I think it's great to ask, what are the risks and what are the benefits? of doing any kind of treatment. What you don't want to do is ask him, should I? As a doc, I'll tell you most people who say, should I, if there's issues one way or another, I'll cover my ass and say, yes, you should. So either ask, what would they do and why? Or what are the risks and what are the benefits? And then you have to look and decide.
Okay, but specifically though, would a Prostox score factor in the decision making?
I think I might be more likely to look at a Barrigel or a bioprotect balloon. One, if the person was competent and comfortable using it, if the Prostox were positive. The thing is, Prostox still hasn't been entirely validated. Prostox is validated with CT guided treatment where they had larger margins. Whether that still holds in using 2 millimeter margin instead of 5, I don't know. So I'd certainly, if I were being treated on a CT guided machine, I might be more likely to consider a gel, and these hydrogels. And John, you suggested that we spell it out in case someone didn't see it. It's SPACEOAR, SpaceOAR. And, that would be my thoughts on it.
Thank you.
Other comments tonight?
Nick, I just want to say to Nick, Nick, be sure to sign up on our website, unless you want to share your email publicly. Welcome, but sign up on the website because then you'll get a reminder before every meeting. So
Will do.
Or you can send an email to me to either me or Alexa. Alexa.
Me.
You can send an email to alexa@ancan.org, and Alexa will be sure to put you up. I also want to give a quick plug for I won't give a quick plug for our Men Speaking Freely because there may be some men who might benefit from that. I'll let our Men Speaking Freely moderator give a quick plug for that and encourage anybody to join us at our next meeting. Go ahead, Dr. John.
Men Speaking Freely is a twice a month, 1.5 hour group that meets on the first and third Thursday nights, 8 p.m. Eastern. And the group is intended as a way for us to share feelings, coping, ideas. We talk about things like, anxiety and depression. We talk about fear, and we talk actually quite a lot about what it's like to be a man, in particular with a scary illness. Although there are people there without prostate cancer, it's for men with serious chronic illnesses. We enjoy the group actually very much, don't we, Rick?
It is a great group, and I'll also say we often talk about ED issues in that group and solutions to ED issues, and also we talk about incontinence in that group as well quite a bit. I mean, I say we don't really talk about treatment in that group, but that's sort of a different. We exempt ED and incontinence from treatment issues, if you like, especially since it's a men-only group. It's sometimes easier for people to talk about it in there. I think that Dr. Mark has disappeared because he's gone to make sure to get Andrew. So we can give not this Andrew.
We're giving the people what they want.
But we want to give you.
One more question.
Okay. Wait a minute. We do have.
Oh, look at that.
How much is that doggy in the window?
That's right.
He's priceless.
What
I
a
tell you
sweet
what.
guy.
Yeah.
Yep, he is, and he enjoys hiding out. He gets an hour without me bugging him.
He missed his. I will say we collared Dr. Mark to come with us to a meeting today, so he missed his regular gig, which is at Burbank Airport, and where he works as a therapy dog for wagage claim, and so he didn't get to do his wagage claim duty today. That said, he's been getting a lot of love and attention from Alexa.
Yeah. It's such a hard job. It's just difficult. I'm really struggling.
Okay,
Alexa,
well,
you
we'll
need
see
to
you
get a lot of rest because I need your help tomorrow.
So I'm gonna be flying back tomorrow, but we'll talk about it, okay? I'm definitely gonna help you though.
All right.
Okay, I guess your buddy, the Colonel, is enjoying himself in Maui right now, Causley. That's a terrible
I think
thing.
so, yes. He's in Hawaii
Yeah.
somewhere.
Okay, well, Alexa will be there. And guys, what we're talking about, and a huge shout out to Causley here and to
Yes.
Alexa. Causley and Colonel Boykin have taken on the job of getting the recordings posted to YouTube and to our blog. And so this recording will become available tomorrow, and then they will annotate it and put everything in that was being discussed. And then it'll be available for everybody to read. And huge thanks to Causley. And we're still in a training mode. And I thank Alexa for all her time and patience.
No, we're not training. We're just partying. We're calling it training. We're just partying. That's all.
With little umbrellas.
There you go.
We're about ready to head out and get some of those umbrellas soon.
Yeah.
Okay.
Everybody have a good night, and we'll see you in a
Thank
couple of
you.
weeks.
Thank
Take
you,
care.
Mark.
All right. Good night,
Good
guys.
night.
John.
Okay, thanks a lot. See you later.
Love you guys.